but also in our nation's capital. So it makes it just that much more exciting to be here and be present while there is so much that's going on. Welcome to today's forum and discussion on menopause and really midlife care for women and women's health. That's become something that is, you could call a groundswell over the past few months, and I would even dare say year or so. And before I sort of go into the deeper part of my presentation or welcome for you all, may I just say, it is about damn time. Okay. I think it is, we are now at a moment in time, some folks call it a menopause moment, where society and science are catching up to what women have been telling us forever, right? That menopause is a transition that affects so many aspects of their lives, and is a transition holistically, emotionally, physically, you name it, and has such a tremendous impact on the woman herself, on the individual themselves, on their families, their communities, their work environment, you name it. Something is happening, and it's about time that we acknowledge what's happening with these women and step up to the plate, right, to stand and deliver, because they for sure deserve it. We're delighted to be here today with such distinguished groups of participants, especially our legislative leaders, healthcare professionals, experts, advocates, and most importantly, individuals with lived experience, right? Who better to drive innovation and drive the voice of those who are experiencing this than those who are among the group that's experiencing it, and and any single one of us will go through our lives without experiencing menopause, even if you are our male counterparts, right? As I said, menopause impacts the community at large. As you know, menopause is an experience that, as I said, all women will face in life. Yet it does remain to be one of the most misunderstood and under-discussed topics in society and in healthcare, believe it or not. The changes women experience during this time go beyond just physical, right? They can impact, as I said, mental, emotional, social well-being, and they really, really impact a woman's quality of life in such profound ways that we are just only starting to acknowledge and consider. Today's discussion aims to shed light on the challenges and opportunities around menopause care, while exploring really some of the critical roles that informed care, support systems, and intervention, especially early intervention, can play in promoting better health outcomes for midlife women. We are only just starting to understand from a scientific perspective that the symptoms that women experience during this transition actually do have impact on their end of life trajectory, right? How they will experience their life in older age, if they will experience life in older age, right? To understand now and start to study and look into how women, especially women of color who experience more severe vasomotor symptoms or hot flashes, actually have worse cardiovascular outcomes, is something, again, that we are only just starting to understand. Our hope is that this forum will not only raise awareness around this, but also create a space for open dialogue, share valuable insights, and help build a more supportive framework for women navigating this important part of their lives, but also for their communities as well. We encourage everyone to participate actively and remain engaged, and dive into this conversation with us. Come along on this journey, because, as I said, the folks that we're representing, the voices that we're representing, sure do deserve it. So before we dive into the panel discussion, the first panel discussion for this morning, we want to begin with a small clip from the trailer from the M Factor, which, as you know, is a documentary that really empowers communities, doctors, clinicians, and legislatures around the world with the information that it aims to bring to light on the subject I've just discussed. And so without further ado, a small clip from the M Factor, Shredding the Silence on Menopause.
I felt myself drawing into yourself and away from everyone, because nobody understands.
I'm a board certified OB/GYN, right, at an accredited program in this country. I got less than a month of training of menopause, and some of my colleagues don't even get that.
looking at the 20th anniversary of the reporting of the Women's Health Initiative and taking stock of what has happened in those 20 years. Very little.
We go through puberty and everybody's happy and excited and you can't wait. And then you go through pregnancy and it's parties. You go through menopause and nobody wants to hear about it.
When I went to the doctor and told them that I diagnosed myself and I think this is happening, they said, well, we'll see, let's just wait and see.
Women who have early menopause have not only an increased risk of cardiovascular disease, but also of dementia. So if something is bothering you and someone says it's in your head, it's like, of course it is. Everything is in my head. And hormones affect your brain.
Our brains run on estrogen starting at puberty. And they keep doing that until the end of our lives.
If you think about the impact of growing up in a racist society on your body, the trauma, it makes sense to me like as you get older, that trauma impacts your hormones.
All of a sudden you get like heart fluctuations, and I thought, okay, it's just that I'm having a panic attack, you know, and so then that messes with your mental psyche, you know, all of it.
Brain fog is a very weird phenomenon that doesn't even actually have a term in medicine, is that these changes can be so severe to prompt fears of either going crazy or developing dementia.
Women say, I just don't feel like myself anymore. I feel like I'm just a different person. Like, who is this person? I've lost myself.
And so I lost a lot of the confidence in the one thing that I knew how to do. If I can't ad-lib, if I can't read the teleprompter and the words that are in front of me, I can't be a journalist.
We have the cost of lost work productivity, women with lost wages. This is an enormous loss of human capital.
A lot of that was breast cancer. A lot of that is pregnancy-related conditions. How much of that really is dedicated to women over the age of 40? We can't even find it. They don't even keep records on how much research is done on menopausal women. That's how little has been done.
I think one of the most damaging things we did to women is that we made them afraid of something their body naturally makes. I think it's devastating.
Is the last third of my life not as important as the middle third in my reproductive years?
I think that there is at least an understanding and awareness that women are not going to stand for it anymore. Women are waking up and saying, what? No one ever told me this. Well, we should all know.
Wonderful. Thank you so much. So at this point, I'd like to welcome our distinguished guests for the first part of this program, which is the first panel. And first up, Senator Patty Murray is Washington State's senior senator. Any place. It's open seating, and a member of the Senate Democratic leadership since 2007, as well as chair of the Senate Appropriations Committee. Welcome. Thank you so much, Senator Murray. Next, I'll introduce Tamsin Fadal, who is an Emmy Award-winning journalist, documentary filmmaker, and menopause advocate. Tamsin is the creator and co-producer, as well as co-executive producer of the PBS documentary, The M Factor, which we just saw a clip from. So thank you. Welcome, Tamsin. And next, I'd like to bring up Denise Pines, who is a Peabody Award-winning filmmaker and health advocate, executive producer of The M Factor, and president of the Osteopathic Medical Board of California. Welcome so much, Denise. So I'm going to take a seat next to you all, and I'll pass this mic over so that we have an opportunity to utilize that. So for today's discussion, I have a few questions that we've put together based on some of the interest around this topic and the interest for this forum. I'll steer some of the questions towards individuals. I don't know if my hair is making noise, on the panel, but feel free to chime in if you have input or would like to add to your colleagues here on the panel as they address a particular question. So first up, Senator, why is addressing the inequities of menopause a priority? Why should people care?
Oh my gosh, well, first of all, this was awesome. I love it. You know, this has been a topic of non-discussion forever, for a lot of reasons. One, as you described, women go to their doctor and they go, I don't want to. They try to get information about it and can't find any. I've had women tell me that, you know, the only person I could think of was to call my mom, and she said, don't talk about it. And I have to tell all of you, this is the first discussion in the United States Capitol ever on this topic. And it's not on. This is the first time in this Capitol that we've had this discussion. You know, awesome, but like, why? Half the population goes through this.
That's right.
And the fact that you can't find information, that you can't talk to anybody, you're really afraid to tell anybody, except like here in the Senate, the women in the women's bathroom might say something. But, you know, it hasn't been a topic we discuss. So in not talking about it, what we have done is made women suffer in this country and actually in the world. And we have to lead, not just for ourselves, but for the entire women in the world. Our ability to be productive our entire lives, to make sure that we are healthy and well and doing the right things about ourselves, and making sure that no one suffers in silence should be a goal of all of us. So this is really an important discussion, and I'm so excited to be a part of it, so thank you.
Thank you so much. May I just add to that it's oftentimes women, you spoke about the discussion in the Senate bathroom, it's oftentimes women who are at the height of their game who are experiencing these symptoms, right? And so it's sad in and of itself, the existence that we currently live in, but to really come to that sort of harsh reality that it's women who are contributing so much to society and driving a lot of the innovation and impact that we know to be what exists today that are being impacted, and suffering in silence is also sort of doubly as sad, right? Wonderful, thank you. Tamsin, the M Factor film emphasizes the ongoing silence around menopause, which remains honestly a taboo topic for many women themselves. Although we are experiencing a groundswell, which is amazing. You've become such a menopause advocate and a driving force after your own personal experience and lived experience with menopause, and just sort of the difficult subject that it is to discuss openly. What challenges have you faced encouraging women, physicians, clinicians, and others to break their silence?
Thank you. You know, I think when I look at it, I was a journalist for a very, very long time. That's all I've ever known. And then I had my own personal experience thinking it was unique, not realizing that half the world was dealing with the same thing because we were so quiet about it. I think that less of a challenge in terms of physicians, because we have some incredible physicians, as we know, who have been talking about this for a long time and have been talking inside of offices for a long time, trying to explain it to women. But in order to get that word out there, I think, you know, we've had to all come together to really talk, and the challenge has been more so this lack of information, you know, so we're talking about it, but we're not necessarily sure what to do after that, and I think that that's one of the big issues. And I think those challenges come from the fact that there's such a stigma around it, there's so much shame wrapped around it, ageism's wrapped around it. I mean, you know, it's a trifecta of issues, not to mention a lack of any kind of normalized language around it. And I think that we need a little bit of all of that. Because if you're not comfortable talking about it, and often we talk about this, the whispering, not knowing who to talk to, finding somebody in the bathroom to talk to about it, and that's just not okay for all the other things that we're okay to talk about.
Yeah. And to look back on the clip, just to think about the experiences that some women are having, and then also thinking about my lived experience as an OBGYN, the women that I saw and would treat, just to picture and try to understand and empathize with just how lonely of an experience it is to feel like you're the only one going through it, right? To feel like, what's wrong with me? Something's not right. I'm losing myself. That is so humbling to hear, and to understand that we have an opportunity to really become a driving force behind pulling individuals out of that space that's so lonely and isolating is just so invigorating and inspiring, honestly. Thank you, Tamsin. Denise, California is taking a leadership role in policy. Tell me why and where success is happening in this policy space.
Sure. The why part is that California is aging. By 2030, 28% of our population, which is about almost 12 million, so 11 million people, will be over the age of 60. And we realized as that became, we had an awareness around that we had to start acting fast. The way our state was set up, we have just too many silos. So as people age into housing, healthcare, other food sources, that they were not connected together. So for me, when I looked at it from a health perspective and looking at it from a menopause women's health perspective, obviously that falls in line with where we're not having enough help and enough care. We have a really large state, up and down, a lot of people in the middle. Dr. Malone is going to the middle, I'm going to the top today. And when we look at that, we see lots of healthcare gaps. Healthcare gaps in terms of just physicians, healthcare gaps in knowledge of this area. And so a number of us have been working with our legislators in the state, mainly on the assembly side. And these are women who, one is a man, but the woman realizes, like, hey, we're not addressing this issue because she started to have menopausal symptoms. She had turned 45 and realized when she went to her doctor, the doctor said, you're too young, right? And when she realized and started talking to friends, they were like, oh, I think you're perimenopause. And that led her to enact a bill. So there were two bills that reached the governor's desk. They went through the House. One was a bill to cover insurance for menopausal treatment. That bill did not get signed. It did not get signed because we have a state deficit. We have a budget deficit. And so anything that's going to cost that comes across like that is not. Because when you look at insurance, it's not just private insurance providers having to cover the gap. It was, in our state, it's called Medi-Cal, which is Medicaid. The second bill did pass. And there we have hope. And we have hope across the entire country because we can get another bill like that passed in other states. That bill, AB 2270, was a bill that recommended, didn't require, recommended that physicians take a CME on menopause, physical and mental health. And so we have a start. And we can create an example state by state by state by passing that kind of bill.
Wonderful. Thank you so much for sharing that, Denise. You spoke about sort of the sheer volume of the state, right? And the aging population. Just a fun fact to share with the group. There are 6,000 women a day in the United States that enter into menopause. Don't be fooled though. The symptoms of menopause actually begin before that technical day that they enter into the definition of menopause. Symptoms begin in the perimenopausal phase, which can be as early as late 30s for some women, right? And so women experience those symptoms for 7 to 10 years before they actually hit the definition of when you are technically menopausal. And it is those symptoms, not the technical definition, that are what's driving a lot of the challenges that women are experiencing. So just wanted to toss that out to accompany the fact that you gave about the state. Thank you so much, Denise. Senator Murray. You led the first bipartisan bill in the Senate that would make and take a historic action to address the menopause and women's midlife health gaps. And we've had for decades. Can you talk about your legislation and how it will help move this conversation, how it will help move the needle around this important topic?
Absolutely, and we address many of the things that you talked about in your film. First of all, we need research. We need research so people have actual research information to be able to provide, that people can access it and know that they're getting quality information that's been researched. So funding research at NIH, which I will just say, as one of my Republican colleagues said, that if men were experiencing this, it would already be funded there, but it's not. So we actually introduced legislation to have it funded. Making sure that there are health promotion activities nationwide, making sure people get information. Training of clinical providers, requiring that nationwide so that I think you said on the film, one woman said that she'd had 1 month in her training. That is not enough. And all physicians should be able to know this, because you don't necessarily go to your OBGYN if you're experiencing a lot of these symptoms. So making sure people, we actually have clinical requirements for people who are physicians and who are seeing women. So it's a broad range of things that we fund at the federal level to make sure that we take action nationwide. And I will just say, as I went to get co-sponsors of this for my legislation, as I spoke to women senators, I said, would you be willing to co-sponsor it? Are you kidding? Of course I will. We now have to get men to also sign up.
Exactly right. That's exactly right. Thank you so much, Senator. Tamsin, following the policy work that Senator Murray is doing, what steps can we collectively take to create a more open dialogue around menopause?
Policy work we're very thankful for.
Yes.
Right. I mean, I'll start with that first part, actually, jumping off of what you're saying, is engaging men in this conversation,
right.
Engaging a younger audience in this conversation. I think it has to start with education, though. It really does. That's how we're going to normalize it. That's how we're going to find this language around it, where we don't whisper it, feel shameful, not sure how to bring it up at work, not sure how to bring it to our spouse. I think we also have to realize that we have to engage diverse voices. Menopause is certainly not a one-size-fits-all, and we have to keep that in mind. And so while we're doing that research, that always has to be part of the conversation. And and I think if we do that, then we can get into that next step. Once we've got that education started, people will ask the next question, now what can I do to seek treatment? And that's where we need to be. I mean, there are some steps that we have to follow when it comes to research, it comes to education, but these women also have to get help.
That's right. That's exactly right. Thank you, Tamsin. And I will add, we talk a lot about, and when we think about menopause, we think about the natural transition into menopause. Sure. But it is important to recognize that there are groups of women that enter into menopause outside of the natural transition, right? There are women for surgical reasons who become menopausal overnight, really, or because they're undergoing certain treatments like chemotherapy treatment, right, which also induces some of the menopausal symptoms we speak of. So really an important topic to make sure we engage a broad body of individuals on. Thank you, Tamsin. Denise, you also help companies become more menopause friendly and menopause aware. What key policies and practices would better support employees going through menopause? How can organizations foster an inclusive environment where menopause is normalized and openly discussed, ensuring that all employees feel supported?
There's a lot of ways, I think. One is first starting the conversation at the executive level, just having that conversation. Have we thought about this? Is there, do we have an ERG group here? Have they been talking about it? Maybe we get the conversation going there. Looking at, getting started with a few webinars, and then looking at how do you expand the webinars into actual real training. How do you train the managers? How do you train your employees or your report to staff? How do you create pathways in HR? So if I'm an employee and I recognize that I am menopausal and I go to my manager, that there is a pathway along that journey in HR to what our healthcare is providing for us, to what that healthcare actually is. Is it going to cover my treatment? Is it going to cover me having counseling if I'm having some mental issues as a result of it? Is it going to cover me to be out of work if I need to stay out of work for a few days? So looking at, the pathway you're going to have the policy engaged throughout. Looking at inside of our handbooks and our work materials, is there inclusive language that talks about women's life stage in there? The same way we have that kind of language about maternity and parental care. So that this is not like a separate side thing. This is all part of our wellness for our employees at our company.
Wonderful. Thank you so much, Denise. So with the last few moments remaining in the panel discussion, I'd like to ask you each to just sort of give this audience a last word on what they themselves can do right now to advance this conversation on menopause. And from your perspective, what good looks like if we ultimately deliver on the outcome that we are intending to deliver on with this type of activity. So Denise, you have the microphone, so I'll have you go first.
Okay. women are thriving. They're happy, and everybody around them is happy. We know that when women thrive, you know, the rest of the world thrives. So I think that's what it looks like. It looks like successful midlife careers. It looks like, you know, women who have grandchildren being able to play with their grandchildren. It looks like women as leaders. I think that's what it looks like. What would I like people to do in the meantime is to watch our film and to press on their legislators and to support bills like the senator's bill when it comes up.
I would say we have to keep this conversation going both inside businesses, inside politics, and outside in every way we can to help grow awareness and allow us to get to the point where in very tight budgets we actually fund what we need to do. What the world looks like to me when we reach this goal is this is an economic discussion for the United States.
Yes.
When almost half your population or more is not participating fully, for whatever reason, we all lose.
That's right.
So it is in the good of our country, it's in the good of our families and our communities and our economy for people to be able to produce at the highest level. We need everybody.
Thank you.
Absolutely. I think I would say this. I think I'm starting to see something very interesting develop. You know, the film has now been shown in 25 different countries across the globe, but not because we put it there, because the women put it there.
Okay.
Women reached out to us and asked if they could show it within their community. So, you know, we've given the film out for free for these communities. We've had hundreds and hundreds of screenings across the U.S. So I see that as a look into the future almost, because it's not about the film, it's about the conversations that are happening afterwards as a result of that. Women want the information, and as soon as they have it, they want to do something with it and share it. So I'm super encouraged by that, and I hope that continues, those conversations, and move it to the next place.
Wonderful. And what can this audience do to help drive that?
Oh, you know, share the message, bring more men into the room. And thank you, but you know, we're always talking to like 90% of, you know, a room of 90% women, and so I think bringing men into that conversation, we have got to do that. And I go back to the younger generation too, because I think a lot of us didn't didn't have a mother to talk to or somebody that was able to share or willing to share with it. So I think that's important to have those intergenerational conversations.
That's wonderful. Thank you so much, Tamsin. And with that brings us to the end of this panel discussion. I'd like very much to share my appreciation and thankfulness with you, Denise, you, Senator Murray, and you, Tamsin. Thank you so much for your time. This has been amazing.
Thank you.
Thank you very much, Senator. Thank you.
Thank you so
Okay,
much.
Sen, it's nice to
Appreciate
meet
it.
you. Thanks, Denise. Oh, thank you.
I have a problem of not being loud enough. Oh, there we are. All right. Now we're going to get started. We're going to bring up our next panelists to have this discussion, and I promise you will be able to hear them. Dr. Angie Lee is a board-certified OBGYN with 14 years clinical experience. Catherine Schubert, President and CEO, Society for Women's Health Research. And Dr. Sharon Malone, DC-based OBGYN and certified menopause practitioner dedicated to empowering women in managing their health. All right, so we're going to dive a little bit deeper in this panel to explore health disparities in menopausal care and how they impact women both professionally and personally. So, Dr. Malone, I want to start with you. Menopause can span up to a decade or longer for some women. We're aware of that, though. Can you share the insights of the long-term impacts of menopause and how they counter common misconceptions that menopause is just a short-lived phase?
Right. Thank you, Tamsin, for that. Can you hear me? Is it on? Okay, better? I think, okay, here we go. Oh, yay. Well, menopause is something that I think that we think of, women tend to think of as an event. And it is not an event. It is a phase of your life that once you are in it, you will be in it for the rest of your life. And not only that, but as we talked about earlier, it can be 10 years before you actually get to menopause. And that is why you cannot just extract menopause and say, we're just going to talk about menopause. It affects every single organ system in our bodies, and it affects our long-term health, be it cardiovascular disease, our brain health, our bone health, our genital urinary syndrome system that will be affected by the presence or absence of estrogen. So when I think of menopause, I like to frame it this way. It's not just about women's menopause and whether or not you are fertile. It is about the rest of your life. Menopause signals a change in women's health that will start and will continue for all that time. So it is something that, even though we like to bring this out because it is a conversation about midlife women's health, it is something that all of us will experience in various forms of the other. And whether you have one hot flash or 100 hot flashes, the same long-term health issues that we talk about, cardiovascular disease, brain health, bone health, and the genital urinary system will be affected. And that's why I think that the conversation is important, but I think that we have to put it in a much larger context to understand that it affects everything.
And it affects everything with regard to health, with regard to work, with
Right.
regard to all aspects of our lives, which I think is what we continue to start talking a little bit more about, I would say, right?
Right. And and I think that, again, a neglected aspect of talking about what happens to women in the menopause transition and beyond is what happens to your brain. And not just the cognitive effects, but the mental health. There's more anxiety, there's more depression as women enter this phase of life. So, think of it as it's everything. And I think that when we reduce menopause, the menopause conversation to just talking about hot flashes or the absence or presence of those, then we're minimizing the effect of what it really means for women. And it is the phase of life that, God willing, if we live long enough, we will all go through. So it is not a partisan issue. It is not, an issue that someone can opt out of. We will all go through menopause. Yay. But I think that when we talk about, the reason why it gets minimized is because we think that it's just about, women whining or complaining or being irritable and being in a bad mood. And if that were the only issues about menopause, if it were just a quality of life issue, what's wrong with improving the quality of women's lives? I mean, that minimizes, again, what women are going through. And so I am delighted that, after 30 plus years of practicing here in Washington, D.C., that this conversation has finally broken out of just an exam room. And not as actually hasn't been in a lot of exam rooms because people haven't been talking about it there either. But now we have a huge opportunity. We've elevated the issue. Women are going to start to get educated about it. And, God willing, we'll be able to get legislation passed because this is a health problem for women in midlife that we cannot afford not to address because it will have tremendous impacts on the budget, Medicare, and the insurance industry, and everything for women in midlife. So, yeah, it's that important.
When we talk about that, let's bring it to the workplace because I think that's where we go next, Catherine. The Society for Women's Health Research recently published the Menopause Workplace Resource Guide for Women. 2 questions. What drove your organization to create it, but how do you envision the guide shaping support for women in the workplace?
Thank you for that. So yes, I mean, Senator Murray said it herself, right? This is an economic issue. And so while we were looking at menopause, and we've been looking at menopause for our entire existence for 35 years, we looked at the lack of research. We looked at creating empowerment tools and amplifying other organizations. And I see some fierce menopause advocates here in the audience. But what it came down to was, how can we support women in the workplace? Because at the end of the day, 75% of women who participate in the workforce experience the menopause transition, and they're working during those years. Mm-hmm. So how can we best support them so that they're not experiencing issues surrounding, and in our study, we found 48% said that self-confidence and self-esteem in the workplace was an issue. So if you're not feeling like you can do your job, you're not going to excel at it. 45% said overall job satisfaction, and they were just done. I mean, people are leaving the workplace in the prime of their careers, and it costs a lot of money to train new people to come in and do that. Presenteeism, 38% of women are not showing up to work because of these symptoms that they're experiencing. And so I think there's a lot of reasons why we want to make sure that we're supporting folks here. And you can see it in the film too, right? Talking about how can HR support these folks who are experiencing this issue. I get it all the time, brain fog, and I just call it out now, but I'm in women's health, so I can do that, right? But I do think at the end of the day, how can we keep women in their careers? How can we keep them participating and being productive members of society? And so we created a guide for women in the workforce, but also their supervisors. Because the other thing that we heard, just like it wasn't coming up in the exam room, it definitely wasn't coming up in the workplace in a positive way. And so how can we support supervisors in starting this conversation? And a lot of times that was men, and they would like to talk about this, but they're a little apprehensive about it. So we want to be able to support them. So that's what the guide is doing. We really hope that employers will use it. We hope women will use it to start those conversations. And so for us, I think it's an exciting time, right? This is not a political issue, right? It's an everyone issue. And so I think we're excited about this opportunity.
Dr. Lee, let me ask you, if there were one thing that women should really understand about the menopause transition, I feel like there's so many, so it's not a fair question, but if there's one thing that women should really understand, what would it be?
Thank you. I think that it's really important to recognize that every woman is an individual, and every person has their own, every person has their own different medical history, different background, different family history, and each person is going to experience menopause in a unique way. If everybody did it the same way, it would be so easy for healthcare providers, because it would just be, one size fits all. But because we each have such a uniqueness about it, then that is where there creates a little bit of a potential for a disconnect between a woman and her provider. To illustrate this point, there was a real-world evidence study called the Realize study, and it sought to assess the alignment between a woman's perspective and what she says that she's experiencing in her menopause symptoms, and then comparing that to the healthcare provider and the healthcare provider's assessment of the woman's symptoms. And if you can imagine, the woman self-reported her symptoms here, but then the healthcare provider underestimated the symptoms that the woman was experiencing. So you see that clinical disconnect, that gap in clinical awareness. And then so you layer on top of that, that we are all unique and that we are all having our unique experiences, and that makes for a little bit of a tricky situation. I think what's super important here is to recognize is that then women, we're used to getting it done, right? But in the healthcare provider's office, then that may look like we need to engage, we need to initiate the conversations. It may not be happening organically in the office visit. So we may need to initiate that. We may need to highlight, hey, this is changing for me. These are some of the things that I'm seeing, and I wanted to talk to you about that. And we also need to be flagging questions that we have as we're entering our 40s, 50s, and midlife.
Dr. Miller, let me ask you, the film touches on hormone replacement therapy. We know there are other solutions because, as we've said, it's not a one-size-fits-all thing that we're talking about. Can you talk about the distinctions between traditional HRT, non-hormonal, bioidentical, and what women should consider in terms of risk-benefit?
Oh my goodness, that's a whole book.
Sit back and grab something to eat.
But let me just, I think just simplified for you. I think that when we talk about women's health in midlife, everyone understands that lifestyle is important. So that's a given. Let's start there. And then once you've done all those lifestyle things, you exercise, you have a healthy diet, you've reduced the stress in your life. Yay, good luck for you. But when you've done that, and you are still having symptoms that are bothersome, what are your options? Well, the most effective treatment for the symptoms of menopause is hormone therapy, and the active ingredient in that being the estrogen. In the hormone replacement, you need a progestin if you have a uterus. No uterus, no progestin, just take estrogen. And we get caught up a lot of times in the semantics of estrogen. But if you think of estrogens and the estrogen receptors in your body, of which there are throughout your body, think of estrogens are like the receptors for the estrogen in your body. It's more like a skeleton key lock. It's not a house key lock. So there are many types of estrogens that will work because they don't have to be exact. But when we talk about bioidentical estrogens, what we are saying is that those estrogens that are usually pharmaceutical, they are the exact same estrogen that your ovaries make. So if you drew it on a chalkboard, it would be estradiol, which is the same estradiol we ate. Does it have to be that? No, but that's predominantly what we use. So when we're saying bioidentical, that's what we mean. We mean a bioidentical, does it look exactly like the one you make? Or is it some, sort of a derivation of that? That's it. Once you've made that decision and you're like, I'm going to do estrogen bioidentical or not, within bioidentical estrogens, there are some that are compounded, which means that they're made especially for you. And then there are pharmaceutical grade, FDA approved bioidentical estrogens. Now, and again, that's an argument about which one, but we do have available cheap estrogens that people can use. So that's sort of, I don't want people to get caught up in the semantics of compounded, bioidentical, natural versus synthetic, because those are basically descriptors that are not meaningful in most cases on a biological basis. So when you've crossed the Rubicon and you've decided that you want to do estrogen, then it becomes a matter of which particular one works for you. But, that's not a distinction that's really worth a lot of conversation. But I think that what we have to understand is that estrogen and hormone therapy will not be right for everyone. There will be women who don't choose to do hormone therapy for their own personal reasons, and that's okay too. The end goal is to make sure that that woman has the education and the information that she needs to make the decision that's right for her. That's all I ask. I'm not an advocate for one or the other. There are non-hormonal options. There are antidepressants that can be used for hot flashes. There are new medications which are, neurokinins that work directly on the brain, but they only work on hot flashes. So which of those options to choose, whether it's HRT, whether it's an antidepressant, whether it's one of the neurokinins that work specifically on the brain, will depend on what your particular treatment goals are. Cost is a factor. Some are more expensive than others. And actually what your risk tolerance is. And it's actually pretty low. But understand that, as we said, not everything works for everybody, but everyone should at least get the information and to be able to choose for themselves. All I ask.
Thank you. Dr. Lee, it is highlighted often that medical education in the U.S. often inadequately prepares many practitioners to address menopause effectively. What menopause-specific training did you receive when it came to medical education, and what do you think we need to do to change what's going on right now?
Well, the film talked about how woefully undereducated trainees are even in OBGYN residency programs. And time and again, we find that to be true. There was a study done in 2022 of all the OBGYN residency program directors. They all participated in the survey, and 31% had some sort of menopause curriculum in their residency program. So unfortunately, I was part of the other, and I didn't actually receive any formal menopause education. So 69% don't receive anything. That's 2022 data. So that is brain fog moment. 1 second. Okay. Oh, okay. And so we really just need to do, we talk about that phrase, menopause. It's not just having a moment, but it's really a movement. And so we need to take that movement towards educating also our HCPs in training, our residents in training, our medical students, because that really needs to be propelled forward as well. Okay, so we need to bring the awareness, and we need to begin to activate, begin to do something about that. And then we're also working to create educational tools. We're working with leaders in education and trying to create educational tools that will resonate with modern learners and that will help to fill that educational gap. It's a really high priority for us at Bayer in our medical group. And so we have a few initiatives that we're working on to that end.
Thank you so much. Catherine, let me ask you something. Based on your organization's work, which I know you cover a lot of different areas, are there specific areas of research in midlife wellness that require maybe the most urgent attention, and then what all of the above, and what pace should we be working to close those gaps?
Yeah, I mean, I do think it's all of the above. And you know, Dr. Malone said this in the trailer too, right? The amount of funding. So first of all, the amount of funding at the NIH for women's health research is really small. It's less than 11% across the board. And then when you drill down, I mean, we couldn't even track menopause. And now we can, so thank goodness we are able to track it. I'm curious to see what the baseline is gonna be. But I do think that if we look at what this moment turned movement is really going to do, is to really focus in during this life stage, right? So it's not just accelerating research in midlife, it's making the case that menopause is important, but also, as Dr. Malone said, the interactions and what it means for your health long-term, for chronic conditions, for the economic costs, both to the healthcare system and just the economy broadly. So things like cardiovascular disease, still the #1 killer of women, we're still winning there, and men. And so we need to think about that. We need to think about bone health. You know, you're not gonna die of a hip fracture until you die of a hip fracture. Mm-hmm. So we have to focus on that. We have to focus on obesity and brain health. And so I think it's a really comprehensive approach that we're looking for to accelerate during this life stage. And so with tracking and the legislation that Senator Murray and her colleagues introduced, if we can get that passed, I think it's going to go a long way. I also think with the White House initiative on women's health research, which, by the way, this is the 1-year anniversary today of the announcement of that. It's very exciting. There's a whole bunch of stuff in there related to midlife. So thinking about how can we continue to carry that message and really make that investment in this life stage is going to be critical. So, I mean, yes, all of it. I think we've seen the start of that, but continued advocacy for it will be important.
And I guess I also think this, I mean, I think about the women today, and Dr. Malone, we've talked a lot about this, but, and you have a phrase that you always say that I always remember, but these women do not have to suffer. And I think that that's an important part. We talk about the research and long-term and what's going forward, but I also think I'm talking about the not suffering today. Can you just, yes.
You know, aside from the long-term chronic health problems that tend to arise after menopause, it's just annoying. I mean, can you imagine what it's like to have hot flashes all day, not ever knowing whether or not you're sitting in your chair in the office, not knowing whether you're going to bleed through while you're in the middle of a meeting, you know, whether or not you are irritable, you're in a bad mood because you haven't slept for years on end. That just in the short term is problematic for women and their quality of life. And what breaks my heart really is to see women, I see them going through that, and they think that the solution is, well, if I just suffer through, I'll just suffer through. And I look at them and I'm like, well, what do you think is on the other side of that suffering? You know, it's not like you get a bonus at the end. Yay, this is why, when we look at menopause and menopausal symptoms, it also matters the ethnicity of the person that you're talking to. And this is particularly worrisome when it comes to African American women. We tend to go through menopause earlier. Our symptoms are more severe, and they last longer. So if we say the transition takes anywhere from 4 to 10 years, for African American women, it lasts 10 years, and the symptoms may persist for years even after you've finished menopause. And that amounts to a whole lot of suffering, a whole lot of unnecessary suffering. And so this is where I say, all right, women need to be aware that there is a solution and it is at hand. And it is not our lot in life, even though we've accepted it, as to just suffer through things. And we as women suffer through a lot. And I'm here to sort of change that mindset. And we've just got to figure out how to do it. The first thing is, we say, we need to educate women so they know when to access care. We've got to educate physicians so they know how to care for women when they come in with these symptoms. But here's the big bugaboo, is that we are facing a severe physician shortage. The over 65, and I think it's by 2030, will be 1 in 5 people will be over 65 in this country, and it is the fastest growing demographic. Who is going to treat these women? Particularly when you have, you got a pipeline you got to fill for getting these doctors up to speed. And this is where I think research is important, technology is important. We have got to figure out ways to deliver care more efficiently than what we have been doing, because even if with the best of intentions, we got all the money in the world, it would take 20 years to fill that pipeline. So this is where I think government has a role. I think that private industry has a role in figuring out how to deliver care and how to get it to the people who need it most. Because the one thing that distresses me is that the quality of your care shouldn't matter whether you live in New York City or you live in New Mexico. And we've got healthcare deserts, and we have women that are out there and that are not getting access to care, even when they know what they want and when they want it. And this is a huge opportunity for us to address. And I have to really say thank you to people like Tamsin and all the social media influencers who have been out there, because they've raised the issue. We've finally broken through, because I can tell you, after 30 years of practicing and talking to women one-on-one every day, one, it's hard to convince them because of the Women's Health Initiative and that big study that came out 22 years ago, because the negative impacts of hormone therapy that they come in with are hard to shake loose. So we've got to understand that one-on-one physicians, I could talk from now till next year and not make a dent. So again, let's raise the awareness. Let's make sure that the issues that matter to us are addressed. But it's really going to start with people being aware and demanding more. And I think we've settled for less because we didn't know we got less.
So true. Dr. Lee, I'm going to ask you one final question, then we'll open it up to questions. As a leader in healthcare, how can Bayer and similar organizations step up to be more proactive in raising awareness and supporting quality care? What initiatives would you like to see from industry leaders?
Right now, I'm an OBGYN, and I get to be in the medical group at Bayer, and it's such a cool thing, because we looked at ourselves and we looked across the room and said, what should we do? And then, and so we decided, let's start at home. Like, let's work within Bayer. So we are bringing in experts in the menopause field. We're super lucky that we get to have good relationships with so many experts, many of whom were in the M Factor film. And then so we are inviting these experts to come in and have lunch and learn sessions with our Bayer employees, and we're inviting everyone, all genders, to attend, and they get to have an expert giving them essentially, you know, a one-on-one lesson here, and then they get to ask questions afterwards. It's been a phenomenal, tremendously positive experience for all the Bayer employees. External to Bayer, we are also working with, as I said, we are really fortunate to have great relationships with these experts in the field, and so we're working with them to create, because not every healthcare provider is very comfortable at this point in talking about menopause with their patients. So we want to help create tools that are meaningful for them and that they can use to feel more comfortable in having these dialogues with our patients. And then also, you know, we talked about OBGYNs aren't the only ones seeing midlife patients. So we are working to support continuing education for the primary care physicians, including family medicine, internal medicine, physician's assistants, nurse practitioners, because we are just trying to get the message out, and we just really want to support the greater awareness. Those are just some of the little things that we are doing at Bayer, and I look across the room and I see that there are many other people representing organizations who are also doing incredible things, and I think that as we all work together in this space, then our ripple effect really just grows. So thank you.
Thank you so much. All right, let me go ahead and open it to a few questions. I don't know how long we have to do it, but if you, I'll point you out. We'll get a mic over to you. I'm going to give them my mic, and just say your name and who you are, and I'll start with the gentleman in the room.
Good morning. Thanks for having this conversation. My name is Jasper Hendricks, and I'm actually here in dual capacity. I'm the newly elected chair of an organization called Mom Congress, but I'm also the executive director of the Black Legislative Leaders Network. And just a couple of weeks ago, I convened 50 primarily black state legislators in Virginia at the Virginia State Capitol, in which we actually watched a film. We had a movie night. It was a 2-day convening, so we had a movie night on the premiere night, and we started a conversation. And I learned a lot of things listening to these legislators. What kind of treatments are available for women versus men when it comes to insurance and what's available. And we actually went down the road of when it comes to black maternal health care. And Dr. Malone, when you mentioned to me that when you mentioned just a few minutes ago that black women are going through this process for 10 years, has there been any research done that maybe this could be a contributing factor to black women dying during childbirth or having complications during childbirth? Like, if we're seeing more black women having children later in life, does this become an issue? And what can we do, or what can we look at to maybe start implementing some policies across states to sort of encourage women to get, to go to the doctor a little bit more, and to ask questions?
Well, there is when we are talking about healthcare disparities, African Americans versus the majority population in this country, it doesn't matter what you're talking about, whether you're talking about maternal mortality, infant mortality, hypertension, diabetes, cardiovascular disease, or cancer outcomes. Those same disparities that we hear a lot about in maternal mortality, they persist throughout an African American woman's life. Now, what is the undergirding mechanism for that? Is it because black women are genetically different? No, it is not. It is because the lived experiences of black women in America are different. It is because we have different access to health care. We have different access to the things that we consider the social determinants of health, where you live, the water you drink, the food you eat, the stresses you are under, the racism that you face in and out of the workplace. And all of those things are undergirding, and there's a concept called weathering Dr. Arlene Geronimus at the University of Michigan has sort of come up with this concept to explain why outcomes are poor. Now, there are some conditions in maternal mortality, not in maternal mortality, but in obstetrics that do increase your risk as you age. So if you have gestational diabetes during pregnancy, or if you have hypertension during pregnancy, yes, those are sometimes harbingers of other long-term health things. But the one thing that I want you to leave from is that when we're investigating these things, a lot of which we know, we know that your outcome is going to be different if you don't have access to a comprehensive cancer center. We know that your outcome is going to be different if you don't have a doctor who is culturally competent in your care. So, when you think about these things, think of them as a continuum and not just individual things to be addressed individually. It is about all of it.
Hi, thank you so much. I'm Claire Gill. I'm the founder of the National Menopause Foundation. My question is, I'm delighted that the M factor qualifies for CME. And it's another great way that we can get clinicians engaged. What recommendations do you have for how we get that opportunity to the clinicians who need it? I feel like we've done such a great job promoting the film and talking about it in the consumer audience. What more can we do to get this film recognized within the medical community for the CME?
Yeah. Can I ask a question of the audience? Is anybody representing a medical professional society here today? Yeah, that's a problem. So, just to start, right? Like, we need to get those folks in the room. Yeah.
That's okay, right? So, hi, hello. CME stands for Continuing Medical Education, right? And in order to maintain your licensure as a clinician, no matter what field you're in, you must maintain a certain number of accredited hours per year. And so part of that is taking part in educational materials, such as the M Factor, and you are then assigned those credits, right? And so it's amazing to hear that the M Factor has been assigned or accredited those CME hours, because then clinicians can use that towards their continuing education. And certainly, myself and my colleague Angie, from the medical perspective within Bayer can drive, to answer your question, can drive awareness around that and ensure that the clinicians that we work with and the societies that we work with understand that this is a resource that is not only chock full of amazing information, but also counts towards the continuing medical credits.
So, in my day job as CEO of Bone Health and Osteoporosis Foundation, we actually do clinical education. So I kind of need to get the link. Like, what do I need to do to send out to the 20,000 clinicians I have in my database? I mean, obviously it's bone, but it's the same thing, to be able to get it to them. And then how do we as patient advocates go to those medical societies we work with to say, this is worth sharing within your community, right?
Hi, my name is Donna Klassen. I'm the co-founder and CEO of Let's Talk Menopause. So we're the two nonprofits in the space. I'm not sure if I have a question, but I just kind of want to say something about mental health, because my other job is I'm a clinician, and I do skills-based therapy around reproductive mental health, and I've seen a lot more perimenopausal, menopausal women, and have been using skills such as CBT and DBT. And one of the things that's missing from this is we're talking about education among medical providers, but we're not talking about social workers, we're not talking about psychiatrists, mental health clinicians. And so maybe it's a question for you, Angie, when you're talking about, with Bayer working on this continued medical education, are you including that? Because my other point is that nobody has studied why the suicide rate among women is highest between the ages of 45 and 64. I even posed that question to one of the top researchers in the country at the University of Pittsburgh, and she looked at me and she said, "Is it?" She had no idea. And so that's not being researched. So what is happening around mental health, and how can we include the psychiatric community, the social work community, and include, and in the UK, there's this debate over CBT, versus hormone therapy. And I would say to that, I'm going to use a skill right here. It's CBT, DBT skills and other options like hormone therapy. We have to use the word and. It's not a debate. It's not a fight. It's not a, right? So that's my point.
At the Menopause Society conference that was just earlier this past year, then CBT played a very prominent role. So I think that it's wonderful that non-pharmacologic methods are also, CBT is very well regarded. So I think that that's wonderful. In regards to, have we at Bayer decided, or have we already started to engage social workers? No, but thanks for the great idea. So yeah, really appreciate that.
Yes. Because they work with women during this age, and especially like reproductive psychiatrists and therapists, they work around this transition, right? And so, I always work around, in particular, fertility issues, and then postpartum depression, and then what happens next? It's sort of like there are those 3 windows of vulnerability of what it's like, and we know that some women are more susceptible to those mental health challenges, and and so we know what's coming next.
And just to try to connect the dots, right? Sorry, I don't mean to cut you off. Just to go off this question. Oh, sorry. I just wanted to point out, and some of my fellow clinicians in the room, including yourself, can either confirm or deny, but hopefully you'll confirm. The mental health changes are oftentimes some of the first things that start to creep in, right? And so what you'll find is that women, not understanding that they're going into this perimenopausal phase of life, not understanding that they're going into this perimenopausal phase of life, will automatically associate that there's something psychologically amiss, right? Layer on now the challenges with sleep, which then exacerbate this further, right? And so I just wanted to point that out because that is such an amazing point that you've made, Donna, and it's also tied back to oftentimes what they're first experiencing. Something's off.
Irritability is a symptom of anxiety and depression, but is a symptom. Oh, she does. And we often blame ourselves for that. Yeah. Oh my gosh, we're such what's wrong with us, and I don't feel like myself, right? But if you understand it as a symptom and label it, right, that's a huge skill. Same thing about a hot flash. I'm having a hot flash right now, right? There are skills that we can do at the same time as doing all these other things, and I think that's super important.
Hi, my name's Jennifer Weiss-Wolf. I'm a lawyer and advocate and writer from New York. And I'm breaking the cardinal rule. This is one of those more of a comment than a question, but it's a little bit of both because I actually want to hear people's thoughts on this. And it's linking also the bridge between CME and policy and all of our own energy and activism. So Denise, I'm over the moon to hear about that California legislation. I can't believe I didn't know about that. Denise mentioned on the earlier panel that it is now required in the state of California for, I don't want to restate the bill, but CME, recommended, and then that's a policy solution. So there's literally an elephant in the room that we're not talking about here today. As we cheerlead and are very excited about the legislation that's been introduced, we're about to enter an entirely different political arena. And so one question is, or one thought that's in my mind, is how we keep all of the legislation and all of the advances alive and kicking in this next administration where, quite frankly, there could be more opportunities or fewer opportunities, hard to tell. And then pivoting it back to the states. And I'm so thrilled to hear about your work in Virginia. There is actually one state in this country now that requires that treatments for menopause be covered by both public and private insurance. It's Louisiana, which probably wouldn't be on everybody's bingo card. And there are real opportunities, I also think, in other state legislatures. I'm already talking to folks in New York and Michigan who really want to figure out what it looks like to create a gold star, gold standard legislative agenda for menopause. I have lots of ideas. I toil away at my computer and think about a lot of it, but I really want to bring all of us in on that piece of the conversation. It's kind of one thing to hold up these ideals generally, and then it's another to think really granularly about what is possible in the next year to take advantage, and 2 years to take advantage of this momentum. I think states are huge. So anyone who is here, who's done the work, who's thinking about it and organizing, I would love to talk to you. I know we all would love to talk to each other. And then really also, I guess, thinking strategically about what it looks like to keep a federal agenda alive. So that's more of a comment than a question, but it's definitely a question.
It's a good
'cause
question.
I know it's what I'm thinking about.
And I'm going to say something, and then I want to hear your thoughts, because I know I asked you the same question this morning. So here, and at the risk of sounding like what I just described to somebody as being a sunshine pumper and being overly optimistic, I do think that there are very real opportunities to have these conversations ongoing. And here's why. At the Society, we've seen 5 administration changes since our founding, and the mission continued. I think, and I'm not sure what the right phrase is, the cat's already out of the bag. We're already talking about it. Do you know how many social events I go to where vaginal dryness is like the topic of conversation? Right? People are, yeah, it's a thing. Every piece of menopause-specific legislation that has been introduced in this Congress has been bipartisan. So that's the key, right? Let's make sure we're pushing it forward. And then the last thing I would say is that the tactics may feel a little different. The strategy is going to definitely change because we are still navigating what we're dealing with. But I think that's the case every 2 years anyway for us. So it's really a matter of just making sure that folks don't walk away. We all have to still show up. We have to have a seat at the table, because if we're not at the table, we're on the menu, right? It's a very DC lobbyist thing to say, but I think it's true. And then this is really the last thing that I'll say. Back in 2018, I was working in the maternal health space specifically, had seen maternal mortality legislation introduced for decades upon decades upon decades. And finally, there was a groundswell of conversation surrounding this because people did not walk away. And President Trump signed it into law. And that was the foundation of what we are now building on with a maternal health momnibus. So I think for us at the Society, we're looking at how do we pull collectively all of these different beyond menopause, yes, and fibroids, and endo, and into a larger package, right? So that we can just keep it moving forward. So more to come there, but I think that's a big thing too.
You know, one of the things I think is really important, and Jen and I have worked together on a lot of things, just in terms of op-eds, of saying, you know, what do we do? And I think that as we sort of organize, we should think about what's the low-hanging fruit. What are the things that don't cost a lot of money? There are certain things that are, you know, yes, should the research be done? Absolutely, but that's years, if not decades in the making before we will get some of these answers. But right now, right today, with the information that we have, one of the provisions of the Menopause Research and Equity Act was really just a review of the current state of affairs of the research that's out there. Review, correct the record, take the things off, you know, government websites that are still misinforming women. You know, because if you broke it, then let's fix it. And that's not going to cost billions of dollars to do. You know, I think that another thing that we can do right now in the short term that will remove some of the stigma is take that warning label off estrogen products. There is no reason why low-dose products should have that. We don't need a 20-year study to figure that out. We know that today. So I think that as we move forward, we just have to prioritize, okay, what are the things, you know, we can do in the next 6 months to a year, and then the longer term ones that we really are going to have to address. But right now, right today, and having an impact would be really, it would be something as simple as PSAs, you know, inform women so they can come in and show this. And this is, there's certain things that are uniquely suited that the government should do. And this is where we've got to work in our small window for how we're going to address this.
Thank you so much. Thank all of you. I appreciate this. I know we want to continue having the conversation. If you haven't checked out the M Factor, it is on PBS stations across the country, and right now on pbs.org as well for a little bit of window there. But I appreciate you being here and taking part in the conversation. I want you guys to have a chance to network a little bit because I see some food back there. But thank you to this incredible panel and women and everything you do every day, not just sitting here today, but all year long for years. Thanks.